Welcome to AETCM, the emergency medicine channel. Today's our topic of discussion diverticulitis. So, in the following of the acute inflammatory condition. So, content of our presentation, definition, and then what are the types of diverticulitis, causes, and then clinical features. What are the assessment point we have to go through in the or we will get in the pre-hospital, complications, and then management in both in-hospital and then pre-hospital. So, what is mean by diverticulitis? So, it is a easy term. So, again itis mean inflammation. So, the inflammation of the diverticulum is called the diverticulitis. Okay. So, then our next question is what is mean by diverticulum? That is our next question. Diverticulum is one of the small bulge or small mass that will present in the or intestine, majorly in the large intestine. Okay, that is called the diverticulum. So, diverticulum means that is a small bulge or that is a small mass that is called the diverticulum, mainly that will present in the large intestine. Okay. So, whenever this pocket or whenever this bulge that is getting inflamed, that is called the diverticulitis. So, here we can see this small bulge or small mass, right. So, this is called the diverticulum. Okay. So, whenever we are calling, so one pouch is there means that is called the diverticulum singular. If more pouches is there means that is called the diverticular in a plural form. Okay, this is the thing. So, where it will occur means mainly it will occur in the weaker portion of the intestinal wall, there only it will occur. So, by telling this you can imagine that image of hernia. So, hernia also the organ will protrude outside through the weaker portion of the abdominal wall. The same image only in intestine, wherever the weaker portion of wall is there, the content will protrude, that will cause the diverticulum or diverticula. So, what are the types? Types mainly we are going to categorize into two different ways. First one based on the wall or layer involvement, second one based on the complication. So, based on the first one, based on the layer involvement. So, layer wise, so again you have to think about that wall of the stomach or gastrointestinal system. First one we have a mucosa, submucosa, and then our muscular layer, finally our serosa layer. So, true diverticula means it involves all the layers of the or intestine, that is called the true diverticula. False diverticula means that will involve only our mucosa and then submucosa, that is called the false diverticula. These are the classification based on the layers of wall involvement. And then mostly diverticula, that lengthwise it will be vary up to 5 to 10 millimeter, it can extend up to 20 millimeter also. And then based on this is based on the layers involvement. Second thing based on the complication. So, based on the complication we are dividing into uncomplicated and then complicated. Uncomplicated means that is a simple term. So, without any complication, inflammation of diverticula with or without Bellman or small abscess that is confined to the bowel wall. So, confined to the bowel wall. So, the diverticular particular area if it is affecting means that won't spread to the another area, that is called the confined wall, it is called the uncomplicated diverticulitis. So, the term abscess we know that is called the pus. So, the what is mean by Blegman? Blegman means, and that is the inflammation of the soft tissues. So, in abscess and pus collection and all we can define the edges, right. So, if some other area if you are getting abscess means we can define the edges, but in Blegman what it will happen means we can't define the edges, it will be like a more diffuse manner, that is called the Blegman. Okay. And then complicated diverticulitis wise it includes diverticular inflammation associated with abscess will be there, stitches will be there, obstruction of the intestinal will be there, fistula, mainly the fistula if it is affecting, most commonly our diverticula we told it will occur in the large intestine. In large intestine also it will mainly affect our sigmoid colon. So, sigmoid colon, there fistula means the anterior of sigmoid colon we have a urinary bladder. So, the fistula happening means mostly it will through the or to the urinary bladder, it's the most common one, and then perforation also can occur. Then coming into causes, we can at causes wise first because of any pathogens. Pathogens wise, mainly bacteria, aerobic and then anaerobic bacteria. So aerobic, again aerobic means gram-negative Escherichia coli and then Enterococcus, Pseudomonas aeruginosa, Klebsiella. Those are the common organism for this one. And then coming into anaerobic organism, that we can tell as a Clostridium and then Streptococcus also, some of the causes for our diverticulitis. And then second, this is for pathogen. Second thing coming into that is the altered bowel motility. So if any intestinal obstruction because of any intraluminal or extraluminal or any intersusception, that is also will alter your bowel motility, thereby it will weaken your wall or the intraluminal pressure will increase, so thereby that hernia can occur. Third one is a behavioral, that is your smoking history, that is also it will increase the risk of the diverticulitis. Obesity also will increase the risk, and then NSAIDs, opioids, steroids also increase the risk of perforation, not increase the risk of forming the diverticulitis, it will increase the risk of perforation. Anyway, ultimately these people will present with our mainly abdominal discomfort or pain. So anyway, we have to choose the NSAID or opioid drugs only. So it is not a risk for the formation of diverticulitis, it is a risk for the perforation. Okay. And then coming into clinical features, mainly these people present with the abdominal discomfort, that is our pain. So pain wherever it can occur in the abdominal region, so based on the location of diverticulitis. But as like we told, mainly it can occur in the, it will occur in the sigmoid colon. So the person will complain the left lower quadrant. Okay. And then the pain, nature of the pain will be like a intermittent or constant pain, mean the same time it will alter the bowel motility. So either the person present with a diarrhea or in other entity that is a constipation, both side it can fall. And then fever and leukocytosis, those are the common clinical features where we'll get in the inflammation. Nausea, vomiting, anorexia, urinary symptoms. So urinary symptoms, mainly if any fistula happens between that or sigmoid colon or from the colon to the urinary bladder means, then you will get all pyuria, dysuria, those are urinary incontinence. This thing will be present in the because of UTI. And then bleeding also is one of the rare with this condition, and then patient have a diarrhea or constipation. Assessment point on physical examination, mainly in the pre-hospital. So we can notice down the first one we told pain. So we can classify the pain based on that mild or moderate severe. So based on that we can go for the management, or while palpation, so we can find out the tenderness, abdominal tenderness, that will be like a mild or moderate to severe also it can go up to. So based on that level of infection or inflammation, it will vary from the mild to moderate to severe. Same time we will get a tender palpable mass. So here we have to note it down very clearly. So if the person have a palpable mass means there don't palpate or there don't give any pressure over that region. So this tender palpable mass means we will get in the our abdominal aortic aneurysm also. There we will get a pulsating mass. So wherever we are seeing in the mass, either that is in the abdomen or that will present in our chest, thoracic cavity, mainly that will present in our abdominal cavity. So we should not pressure over that area. There is one of the thing we have to keep in mind. And then here also we can see the distended abdomen because of any bowel obstruction, and then peritonitis, rebound and then guarding abdomen also we can note it in the physical examination. And then if you are coming into in-hospital, mainly we can go for the any laboratory investigation like serum panel, like panel like a CBC, and then some other things like a C-reactive protein for the inflammatory markers, urine analysis, and then urine culture also we can go for, and then imaging studies wise USG and then CT we can go for the definitive diagnosis purpose. So what are the complications that can arise in abscess and then diverticular hemorrhage and then intestinal fistula, so through the two or urinary bladder. So one of the most common one, and then intestinal perforation can occur, intestinal obstruction, and then finally sepsis and then septic shock. So management pre-hospital, here also only we are focusing on the supportive care. So pain is one of the most common one. What we are going to manage in the diverticulitis, keep in mind the remaining things, airway, breathing, circulation, disability, exposure, that always, that's a constant management. Apart from this, in more specifically in a diverticulitis, first we have to manage the pain, that is abdominal discomfort, person discomfort, that based on that mild, moderate, severe category, either you have to choose NSAIDs or opiates, that is up to our choice, and then based on the person's condition. Second one, the sepsis and then septic shock, that we have to thoroughly we have to assess, and then we have to monitor, we have to treat that sepsis and then septic shock. So again, the sepsis wise, the common thing, fluid management. If it is again refractory, that hypotension is refractory, means then you have to move on the or norepinephrine, vasopressors, vasoactive agents for the maintenance of the blood pressure. What we are doing in the in-hospital means it mainly focused on the supportive care, also supportive care, dietary management, and then antibiotic therapy is a major treatment options in the in-hospital region. So we told, right, uncomplicated, complicated. In uncomplicated cases, we'll go with an like piptos, like our piptos means piperacillin tazobactam cases, or meropenem. So if the person is higher risk for that collapsible state, if the person have any life threatening condition means, then we can go with an meropenem, that's a higher antibiotic group, or piptas drug of choice, or else they will go with an metronidazole along with an ciprofloxacin also, one of the thing they will antibiotic groups. And then diet wise, we have to, in acute episodes, no dairy foods, and then we have to ask the person to avoid the red meat because of the problem in the digestion, right? So these are the two things you have to ask the person to avoid. And then complicated diverticulitis, here also that antibiotic management, mostly they will require the in-hospital admission, and then bowel rest, IV antibiotics, and then treatment directed as a specific complicated or needed. So based on the complication, if it is a perforation or abscess means, along with an or diverticulitis management, you have to manage the complications also. So do your best. Shalom.